everyone. Welcome. Welcome, everyone. We're just going to wait a couple minutes here to get everyone logged in. Feel free to pop into the chat and introduce yourself. Let us know where you are calling in from or zooming in from, what your role is in long-term care. Or unmute yourself and say hello.
David Clinton Baker. I'm a physician in long-term care working in 2 facilities in Victoria.
Welcome, David.
Here.
Hello, this is Dr. Husband here.
Hello, welcome.
Thank you.
Hi there, it's Dr. Dale Nickel calling.
Hi, Dale.
Hi, Jessica. Hi, Romayne.
Hi.
Hi,
I'm Anoma.
Hi. We had 185 people register for this one, so that's probably one of our highest numbers yet. So just give it a minute here for people to sign on, and then we'll get going. In Victoria, property taxes are set to rise sharply as the city copes with inflation.
I am Selena.
Mari. Mari. I was
Hi.
logged in and I went to try to touch something to mute or whatever, and then I lost the pin.
All right.
Hi there, Dr. Azim Ladhani, Medical Director at Belvedere Care Center in Coquitlam in long-term care.
Oh, welcome.
Thank you. Looking forward to the session.
So welcome, everyone. So this is our first Victoria South Island LTCI Learning Series 2023. My name is Jessica. Please excuse my coughing 4-year-old. I'm the Victoria South Island LTCI Program Manager. I'd like to take a moment to welcome you to our LTCI Learning Series event this evening with Dr. Romayne Gallagher. It is with great respect and appreciation that I'm speaking to you today from the traditional and ancestral territories of the Sauk Nation, where I am very lucky to work and live. So firstly, just a couple of housekeeping items. Please keep yourself muted during the event unless you'd like to ask a question. This is a CME event. A certificate will be emailed to you in the coming days by a member of our team. Please take a moment to complete our evaluation form at the end of the event. Your feedback is very important to us. This event will also be recorded and placed on our website along with a copy of the slides. Please feel free to share the link with your colleagues who are unable to attend today. We'll share a URL in the chat. If you have any questions throughout the evening, please unmute yourself and ask away. We like these events to be as interactive as possible, and there will also be plenty of time at the end for discussion. So last but not least, I'd like to introduce our presenter for this evening, Dr. Romayne Gallagher. Dr. Gallagher is a clinical professor in the Division of Palliative Care at the University of BC and the founding director of the Division of Palliative Care from 1997 to 2003. During her tenure, education in palliative care was established in undergrad and postgrad medicine, as well as an interprofessional course. Dr. Gallagher also established the first public forum on death and dying, which ran for 5 years and was replicated by others in North America and Europe. Romayne Gallagher retired from clinical practice in 2018 after 34 years of working in multiple healthcare sectors. She spent 12 years as a family physician, providing palliative care consultations before leaving her practice to do full-time palliative care in hospitals, long-term care, and the community. She has been a physician program director of Providence Healthcare's Hospice Palliative Care Program and physician program director for the long-term care programs at Providence Healthcare. She has over 25 years of experience as a consultant in palliative care. Through her work with the Doctors of British Columbia, Dr. Gallagher established the BC Palliative Care Benefits Program. Dr. Gallagher's other area of clinical and academic interest is chronic pain in older adults. She has numerous peer-reviewed publications, academic writing, and opinion pieces. Dr. Gallagher is a board member of the Canadian Society of Palliative Care Physicians. So without further ado, please welcome Dr. Gallagher.
Hi, everybody. Thank you very much. And I really look forward to having a conversation with you. What I'm hoping to do is to interest you, show you some information, and then see if we can have a discussion about various things that are going on in long-term care and how we might make this better. So can you see my screen okay there?
Yes, we can.
Okay, great. So, suffering in people with dementia, and what I really want to talk about is how does society, policy, and even our own behavior contribute to the suffering of persons with dementia? Before I start that, I've got to do all the faculty presentation disclosure. I don't have any conflicts. I haven't received any major support for this, and mitigating potential bias is not applicable. What I'm hoping to do is identify key themes of suffering. I talk about the stigma involved in having the diagnosis, understand the role that palliative care can play in maintaining quality of life. And don't mean palliative care specialists per se, but I mean by taking a palliative approach. And want to talk a bit about making change in the way we view those with dementia and how we can improve their quality of life. So I'm going to talk about some history. I think I've become more interested in history as I get older. And I never took it in high school, figuring it was too boring, I guess, compared to science. But now I realize that really we have examples that go back many decades that we still have yet to learn from. I'm going back to the time when René Descartes wrote his discourse on the method of rightly conducting one's reason of seeking truth in the sciences. And in this, he basically makes this famous statement, "I think, therefore I am." And he was referring and talking about this with respect to scientific approaches and scientific methods. But unfortunately, it's kind of been adopted as the sort of key element of, what it means to be a human person. And this is rather unfortunate because he only meant it to be about the scientific method. So with that in mind, we've kind of taken this kind of what some people call a hypercognitive society, where we kind of view only that. So if we move on to the next slide, the history is very interesting, the history of Alzheimer's disease, because up until Dr. Alzheimer wrote a case report in 1906, basically, people didn't really talk about this very much. It was thought that once you were over 65, if you began to get forgetful, that was senile dementia and was considered a normal part of aging. And so nothing was really done about that. What he wrote about in 1906 was this patient of his who was 54, Auguste Deterre. You see her photo there. And she developed a very rapidly progressive, as we have seen, kind of early dementia. And when he began to explore that, he wrote this case about her developing this and then rapidly progressing to being immobile, as we know what happens with advanced dementia, and then dying. And he sort of promoted this idea that fibrils that he found when he dissected her brain after she died, the tendrils and fibrils and the various changes he saw neurologically were actually what was causing her dementia. And of course, we now know that that really isn't true, although I must admit some of the recent drugs that have come out for dementia have once again been focusing on those things. So he did this case report, and what happened is in 1910, a colleague of his wrote about it and called it Alzheimer's disease. And what happens with medical care over the 1900s is that people realized that as people got healthier, they lived longer, they began to be more people who began to have problems with memory in aging. And so many people, government officials, family members, caregivers, neuroscience researchers were pushing for the dementias to be seen as a disease, because there was also this push to say, hey, some people age in a way that they don't get this problem. So we need to look at this as more of a disease than just a condition of growing old. Now, unfortunately, to make a compelling case for funding research aimed at treatment and prevention, advocates kind of got on this bandwagon of what critics have called apocalyptic demography. And it's sort of like saying, basically, we began to talk about what all the worst things were about dementia and to focus on what people had lost. Hence, you see these things, the living death, death in slow motion, Alzheimer's disease down in the left-hand corner there, that caring for the living dead, and then a U.S. hearing special committee, which entitled their report, Endless Night, Endless Morning, Living with Alzheimer's Disease. So there was this kind of thing like, people with dementia would become zombies and kind of take over the world. It was done with good intentions to try and promote the treatment and so on, but it's kind of backfired in a way. And a lot of people have sort of said, was this kind of a terror reduction mechanism? We sort of convert the mystery of aging into the problem of aging and then try and find a technical solution to it. There's nothing wrong with trying to find a solution to it. It's just that most of the funding has gone for early detection and prevention as opposed to helping people to live better with dementia. And even now, I think people are a lot more sensitive to this. But even now, if you go and say Google images associated with dementia, you get these kind of awful images that you see here, like one's brain sort of blowing away like dead leaves, a woman alone, sort of tottering down a black darkened hallway. She's faceless, she's unidentifiable. And then this is the bottom one, supposed to be a picture of a long-term care room, which is supposed to look attractive. And it sort of looks nameless again, like this is not a person's room, this is a body's room. And I hope you can I hope you feel the same way when you look at these pictures. Now, it's very interesting in the way support groups have developed, because if you look in, say, the Canadian Alzheimer's Society was founded in 1978, they didn't have a support group for people with dementia until 1993. And I can bet you probably the day after the Cancer Society formed, or it may have even formed because of the desire to support people with cancer. with the Canadian Society, Alzheimer's Society, it was 2003 before a person with dementia actually sat on the Society's board of directors. So there's been this really kind of there's been this kind of understanding of dementia as viewed from the perspective of society and the caregiver, without involvement of people with dementia. In the past 10 years, there's been a lot of people with dementia publishing books about their experience, and I think this has been enormously helpful in kind of giving people insight into the stigma, supporting that whole idea that a person with dementia dies inside a living body, and that's really problematic. And I think, unfortunately, medicine has really contributed to that because we've tended to view losses from a sort of medical perspective. And we haven't really, we focused on what's gone instead of what's left. But that's the way medicine often works. It's just that when we're trying therapy, we need to focus on different issues. And if we think about person theory, which I'm no expert on, but I found this fairly simple explanation of person theory. Our first self is our personal identity, our point of view, our beliefs, the narratives of how we would tell our life. And it's also very basic things, where we are in time and space, and whether we're cold or we're hot, sort of basic body feelings. Self, too, is the traits and skills and our beliefs regarding these attributes. And so this would be people talking about what kind of education they had, what kind of skills they gained, how they've tried to cope with dementia, and how they've tried to deal with this. There may be multiple versions of this. As you know, some people tend to represent themselves quite differently in public as they do at home. So there can be multiple versions of this. And then, sorry about that. Self 3, how we perceive ourselves to be seen by others. And this is a very interesting part of this, because this focuses really on how other people see us. And if they just see us as someone who's lost our memory or lost our cognition, we tend to be seen only as a patient. And so oftentimes that's very, very challenging for people. Whereas if we are seen by others as a person who has attributes, has had skills, may still have skills present, this makes an entirely different picture of that person. The thing is that even in advancing dementia, with really, let's say, advanced dementia, we still get some persistence, and a significant persistence, of self 1. That is how someone would describe themselves, whether they have preserved abilities despite losses of cognitive functions. They can still give us information. They can still listen and respond to music. They can communicate to their ability. And they may be able to communicate these assessments quite well. So I'm trying to focus on what still exists, the spiritual side of the person, all these other issues that we tend to forget about when we get into our sort of hypercognitive thinking mode. So if we're going to consider the landscape of suffering and dementia, there have been some very interesting articles written recently that tend to have interviewed people with early to moderate dementia because they're still able to communicate quite well. And they can talk extensively about how they've been impacted by this disorder. And I think it's quite interesting what the person who wrote this paper said in their introduction, and sort of said the way certain conditions and phenomena are understood and conceptualized shape professional approaches to treatment and also socio-cultural perceptions of those experiencing them. This in turn has implication in terms of the experience of the individual. And I think that's really true because what this study found is three major themes. First of all, people living with dementia live with constant change due to the loss of cognitive capacity and also their altered perceptions of the physical environment. Secondly, they are striving for continuity by using a variety of coping skills. So you've probably all met people with dementia who say would carry their name and address with them, or who would learn to inquire from other people about where they're going. I've marveled often at how people tend to escape sort of saying, I don't remember, and instead say, you've got to talk to my wife about that. She's the one who usually takes care of that. So people have all these ways in which they cope with it. The third thing is the double-edged impact of the environment. And this is where we get down to what that environment means. Because environment is both the physical and the relational environment. In other words, you can be trying to negotiate a physical environment, and there are many problems with that for people with dementia. But also the people in the environment and their relationship to you make an enormous difference. And this is where the work of someone who was a dementia researcher, Tom Kitwood, became very powerful, because he talked a lot about interpersonal relationships being enabling or disempowering. And he actually talked about, which I think in a way we've kind of shown, is that there's a kind of malignant social psychology of the way we treat people when we sort of believe that they're not really a person. And that was he talked about things called disempowering people, no unsupervised walking, treating people like objects during personal care by you not saying, this is not informing them what you're going to do, not greeting them, not doing this, not doing that, imposing, not allowing people to have choices, not infantilizing people, not giving them things to look at or things to do. All these kind of ways in which we kind of treat people as if they're not there. And, many a time, and I'm sure I've been guilty of it myself, I may have come up to someone with dementia and spoken mostly to their caregiver rather than talking to them and their caregiver. And I think in all those ways, we have treated people as people who are less than people. And unfortunately, a lot of people have shown that that has led to people kind of turning off. Well, if I'm not going to be recognized, or I'm not going to be offered anything to do, then I'll just tune out. And there has, been some studies showing that that may lead to further cognitive and physical decline as people become lonely. they become depressed, and so on. And so that's problematic. So Tom Kitwood was very much about maintaining personhood in dementia. And I like the way he called it. Personhood is a standing or status that is bestowed on one human being by others in the context of relationship and social being. It implies recognition, respect, and trust. And, you know, that's how we expect to be treated when we go somewhere. And for many people who might be having trouble with dementia, and you may have seen the ads on TV from Health Canada, where the woman is shopping and loses her list or something and gets into a bit of a panic. That rather than people being frightened by her, there are people in the grocery store who've had some training in how to help people with dementia, to reorient them and help them feel welcome and not shamed, basically. People have often have also sort of said, well, maybe, you know, rather than people, we should focus on citizenship, because citizenship is a status bestowed on those who are full members, and it implies power, that they actually have certain rights to things and so on. It's really interesting. I think either personhood or citizen. Personhood seems more individual and personable somehow. But either of these two things, I think we need to be very much aware of how we are treating people without even thinking about it. And this goes back to Susan Sontag's Illness as Metaphor in 1978, when she wrote about people with cancer and people with TB. And she wrote, the very reputation of this illness is added to the suffering of those who have it. And for many people, it's very true that, you know, the thought of a lot of people, you can read polls as if, you know, it's the most feared disease. And it's surrounded by images of loss of memory, loss of intellectual function, loss of language, all these things. But the thing is that we focus so much on what is lost and what we think are the key things of being human, that we forgot, little attention is paid to what remains and how we can work with that and help people out. And I think we have paid little attention to the ways in which, say, for instance, dementia may be socially produced and reproduced by the unequal power relations between people with dementia and their family members, service providers, professionals, etc. And I think there's been a whole culture that's grown up around that, that has not promoted these people to maintain what they've got, but has sort of disempowered them. Now, I thought that I would just sort of talk a bit effects on policy effects, but then ask, I'd really appreciate it if people would jump in. And you could put it in the chat, but it's hard for me to keep monitoring that. But feel free to turn off your microphone and comment. I mean, I sort of think of some of the policies in long-term care. We've often focused on safety over the ability to explore or exercise or be outside. In order to keep people safe, we've kind of walled out the community, and people talk about warehousing. Falls are recorded as solely as a sign of neglect versus the ability to explore the environment. I'm not promoting falls and hip fractures here, but I'm just noting our view of them as a sign of neglect. And above all, our indicators don't really measure quality of life. They tend to focus more on safety and so on. Does anybody have any comments or questions?
Dr. Gallagher, this is Catherine Ryan. I'm a nurse practitioner in long-term care.
Yeah.
Hi. You know, it's so interesting. I mean, I think about this so much, but the notion that you brought up around being so obsessed around safety, you know, I know we are, and for some good reasons, but it just occurred to me that, you know, when we're having goals of care conversations with people about the type of medical interventions they would want, what a great opportunity to ask them, you know, what they feel about safety measures and what sort of limits they want put on themselves, and, you know, what risks they're willing to take, you know, while they're still in a position to maybe make those comments.
Yeah, I mean, absolutely. Especially, I mean, oftentimes these discussions need to come before people come to long-term care, right? Or at least you hope they might have had them with their family. Because I recall looking after a wonderful mother and daughter where mother had the dementia and tended to wander, but daughter was blind. And so mother would end up out on the street without daughter being aware. But they worked out a solution, which was a talking door opener, so that it kind of alerted her to that, because she didn't want to kind of lock the doors and not let her mother out, right? To be able to go out in the garden versus going out on the street.
Right.
Any other comments? I mean, I think that's an excellent idea, because we spend so much time gathering the MDS data that oftentimes we unfortunately may not have as much time as we would like to find out about what kind of a person is coming to our facility. Any other comments?
Sue Hunter from Comox. I totally agree with this concept of allowing a person to live and live with some degree of risk, because there's sometimes this assumption that they've been falling at home and went not as strong, and somehow coming to care, they're suddenly not going to fall anymore. And unless you force a person to sit or lie in bed, that's not really living. And it's similar to when people eat. Sometimes you have to accept they may eat with some risk for the.
Absolutely, because if for many people eating is a huge pleasure, and it's something that they can still do and partake in and enjoy the social aspect of it. So to say, no, I'm sorry, you have to take this lemon flavored gel sort of stuff is hardly seems to be maintaining her personhood.
I have to agree. Andrea from Victoria here. I have to agree about the personhood. I think sometimes care is led by families, and they have a real focus on safety rather than quality life and personhood. And I think that it would be great to have more education around that, or agreement on that, because the previous person that just commented mentioned that there is an expectation that they're going to come in and no longer have any falls, or no longer going to have any moments by themselves. And really that maybe they enjoy some time to themselves. You know, I know that I do, and that's just part of who people are.
Right. And I think oftentimes I hate to say it, and I'm sure I would have the same problem, but family members may be sort of putting their own feelings of guilt onto their parents, because they feel guilty about having to have them in a facility or whatever, or it could be spouse, and that often really, really complicates things. I have often wondered if the resident family councils could undertake some education with professional people to talk about those feelings and talk about some education around looking differently at dementia.
Looks like we have a question in the chat from Natalia. How to overcome a current policy and have some able-bodied folks discharged from facility with supports. How the GP can help.
Yeah, I can expand a little bit on this question because, like when people in a facility that is run by health authority, the social workers do the assessment and then say, no, she's not safe to go. And it's really hard on some of the people. Yes, they do have dementia and so on, but I can see that they can function in their own environment. Yet my word is nothing compared to the assessment team, right? So I don't know how to deal with it.
It is really difficult, isn't it? I mean, I had the pleasure. It's a pleasure now. At the time, it was difficult. Our neighbor was 90. Oh, I don't know. She was 96 when she died, and she'd lived in her house since she was 8 years old. And she knew the environment really well, even though there were terrible dangers in there, which she insisted upon, like leaning out over the kitchen stairs to put her garbage in a bag hanging out over the stairs. And you're just thinking, oh God, but that way she got to die in her own house, right? And die in the bed that she had been in since she was 8 years old. I hope she changed the mattress, but you know what I mean. Familiarity gives people a sense of control and a sense of being able to kind of live their own life and live a meaningful life for them too. But I think we focus way too much on safety, and I think part of the problem is the act that the community, what's it called now? I forgot it, but the assessment act that looks at community long-term cares and, wants to measure their weight to make sure that we're not neglecting them and not feeding them. Again, that's always been a problem for palliative care because it's pretty normal for people to lose weight when they're dying, and that's the kind of changes that people are having. Anyways, should we leave that for a bit and we'll move on to talk about some other things? I really appreciate all your comments. I think that's very true.
I just wanted to say one thing. I'm also in
Yes.
Victoria with Andrea, and thank you for mentioning that because we do have things like licensing they're stuck with how they have to approach things, but it tends to sometimes be on that negative side, especially when you're looking at falls and a low to no restraint facility, so we have more falls. But there's also that quality of life and the right to live at risk. And
Absolutely.
We had that very discussion today about a gentleman who's been going to the gym and getting stronger, and so now he's trying to walk more. And so staff are worried about him because he's, a higher risk for falling now. But I don't want to live in a wheelchair. I would rather be able to walk even if I'm falling the odd time, so it's really interesting how things get measured. But I love that you brought up the personal care and really what does that mean? What's important for the person? Thanks.
Yeah, well, absolutely. And I think I've often noticed that the culture in facilities is different, right? Some places will really have a team approach and try and allow people to make as many decisions as they possibly can within reason. But this is very challenging given the regulatory environment, and I really think we need to relook at the provincial legislations that we're bound by. So I'm going to talk a bit about quality of life in those with dementia, because people often, talk about, there's of course a person's self-report and proxy reports, and I'd like to commend our Isabel McKenzie for doing a quality of life survey in long-term care, because I really think those are far more important than some of the indicators that we're forced to keep track of. Some of them are useful, some of them are really not useful. A lot of them just don't relate to quality of life. It's very interesting because there are studies showing that people with a mini mental score as low as 10 are still able to rate their quality of life. And it's almost universally higher than that of the proxy reports. So in other words, caregivers, both family and professional, to tend to rate the person with dementia's quality of life lower than the person themselves does. And that's been shown time and again. The only time when they tend to agree is when the quality of life is rated poor, and usually then the caregiver is attuned with that, and may even be more attuned with what's making it poor, be that mood, pain, or lower ability to function physically, that is. Pardon me. So it's very interesting. It'll be interesting to see the results. I'm not sure how this is being carried out. I would hope that it will be something, whereas if the person can't participate, that they are tried at least several times and tried with various scales and so on. We do have quite a bit of information, though, about what living well with dementia looks like. So we know the factors that help people to feel that they're living well. And, interestingly, it's not, if you look at this slide here, living well with dementia, moderate impact to social engagement and good relationship with family care, being able to still practice their spirituality and religious beliefs. And interestingly, they also feel much better if their family carer, if their self-rated health is good as well. Lesser but still important are better functional abilities, their self-rated health. People's self-rated health has always been pretty good at representing how they're really doing. And people actually like living in a specialized dementia unit, probably because they have more freedom there than they do in places where there can be more use of restraints or less freedom to kind of wander about. Interestingly, negligible effect on quality of life was cognitive test scores or self-rated memory function. Now, if you talk with people who are well, they usually say, oh, I would absolutely hate it if I couldn't remember things anymore and I couldn't remember who my family is. That to them death would be better, but it's often interesting, as we've seen many people learn to cope with this, learn to find an outlet for their personhood in other ways. and learn to find quality in amazing ways. So the resilience of humans are amazing. There have been, and these are pictures of Hogweg in the Netherlands, where they have functioned on sort of giving people a good garden to wander in, letting people participate in day-to-day routines such as getting the vegetables ready for dinner, shopping, sitting, having a glass of wine. It's interesting, although I must say, having been to one of these talks where the people from Hogweg were talking about how it was developed, you know, they don't have the same sort of requirements. They're allowed to choose who can come to their facility. We're not allowed to do that in British Columbia. Of course, we have to take, you know, unless there's some dire reason why, we don't really have much choice. They are allowed to choose, and they also, many of these facilities have higher costs and so on. But I still think there's room, even in older settings, to emphasize where people can have more choice, even the time they get out of bed or the time, you know, they have their meals and so on. I'm sure we can try to do better. Now, interestingly, with the Hogweg place in the Netherlands, they have houses, and visitors are not allowed to go into houses, which is true, because that would be very depersonalizing, right? Like, I'm just going to treat you like a zoo animal, and I'm going to come in and see you in your room. But what that hides is 40% of the people that they're caring for are not leaving the houses, probably because they have more marked physical impairments or cognitive impairments. So oftentimes what we're seeing is kind of the best of. Now, what they tend to say is that you know, because they keep people walking and talking and socializing and exploring, their people tend to stay well longer. Unfortunately, they won't have themselves compared with other facilities, so that's hard to know. It does intuitively make some sense that if we could keep people enjoying themselves, being engaged, having more choice and more autonomy, that they would do better. But I think the proof, we're still awaiting some kind of proof on that. Has anybody been to Hogweg? Has anybody seen this at all? Or similar places? Because I think there are places throughout the US, Australia, New Zealand, etc. No? Okay. I believe there's a place in Langley which is trying to emulate that, but again, I believe they are a private facility. So it'll be challenging to see if we can bring this along under the publicly funded system. So in talking about maintaining people's quality of life, this is where I think palliative care might be helpful. And I think by preventing and treating symptoms and illness burden that impair function and reduce quality of life, palliative care can be very useful, not just when people are dying, but when people, to help people continue to live as well as they can and keep their quality of life up. There's actually, if you look at studies looking for people with an intervention specifically with dementia, there's a real paucity of high quality studies. But there is a 2019 systematic review of home palliative care for people with dementia showing potential benefits of home palliative care interventions. And it shows that they managed and reduced behavioral disturbances in people with dementia. So, but there's certainly barriers to doing this, certainly in the home, one being the lack of funding for any kind of care in the community. But hopefully we will one day have more impressive evidence for that. The problems, though, if you look at people with dementia getting to actually get in touch with someone with who may have palliative care expertise, it's pretty difficult. So this was a 2018 study put out by CIHI that looked at the number of people who had palliative care. Now this was by cancer diagnosis, looking at the setting of care and finding that if they had cancer, they were more likely to be seen by somebody. And they were far more likely to be seen by somebody if they were in home or acute care than long-term care. And then again, if you look at the diagnosis, you can really see where in long-term care, if you've got dementia, your chance of receiving palliative care in the last year of life is quite low. Now, you got to realize the limitations of what CIHI is measuring. So if the team in the facility is providing quality palliative care, that is often won't be captured in the data. But the kind of thing is oftentimes people say, well, we don't have access to palliative care. We don't have anybody coming regularly to see them. When I worked in Providence Healthcare, we made sure that we had palliative care nurse and physician who were dedicated to long-term care, and we're kept very busy. Because there's lots of work for us to do there, and not just with people who are dying, but it's people who are trying to live. And we're trying to improve. And the factors really impairing quality of life are depression, high disease burden, and this could be from the dementia or from other comorbidities, a loss of function, and last but not least, pain. So this is from 6,279 people where they did a systematic review. And these are the kind of things that tend to really burden people. The other thing that I think we need to keep in mind is the impact that dementia has on the other comorbidities, because this study here where they took 1,800 people with dementia and compared them to age and sex matched people without dementia and followed them for 5 years, you can see the difference in the 5-year mortality rate, that 50% of the people with dementia had died in 5 years, but only 30% in the control group. And certainly it's generally thought the mortality risk was 1.5 times higher for people with dementia. So, that can help us in planning and talking about people with the kind of way that they would like their health care too. If we know that dementia does have an impact, because I always remember people who, where family members would say, well, all my dad has is a problem with memory. And there would be their dad sitting there, unable to feed himself, unable to dress himself, unable to walk. And they'd be saying, my dad only has a problem with memory. So it's very important, as someone also said, that we educate people about dementia, about how it tends to impact the person's physical function as well, because oftentimes, sadly, people think that's because, oh, it's because they put everybody in a wheelchair, or oh, it's because they can't eat because the staff aren't feeding them. You know, those kind of things, which are misunderstandings, which are kind of hurtful for staff and family alike. What we're learning about, though, with recently is how a lot of the disorders that we're dealing with come back to neuroinflammation, and neuroinflammation is really an activation of microglia, and microglia and astrocytes are the cells that surround the neurons. And they release all kinds of chemicals which produce an inflammatory reaction. And they can cause significant changes and damage. And they may be a key pathological driver of many of the neurological diseases, including neurodegenerative, psychiatric, and pain and stroke and traumatic brain injury. So perhaps there might be some help down the line for how we can help deal with these illnesses through changing inflammation. And we do know that chronic pain may also relate to neuroinflammation. We know that pain and depression are associated with each other, so that if you have pain, you're more likely to be depressed, but also if you're depressed, you're more likely to feel pain. And so the thing is that tends to get the focus is the neuropsychiatric symptoms that we see, which can be agitation, could be refusal of care, wandering, or it could be just hiding out, not wanting to eat or drink or mix with anybody. Unfortunately, those symptoms we tend to focus on, but oftentimes we don't focus on what the underlying cause might be. So, you know, a lot of those can be inadequately treated pain or some other kind of need that we are just not recognizing. And unfortunately, we don't tend to, because people are unable to communicate with us somehow, they, you know, as their dementia progresses, we know that pain is not reported as much. So the lack of communication really hampers our ability to deal with this. We do know, though, that if people get adequate pain management, they have improved symptoms of depression, apathy, and nighttime behavior. As I said, the prevalence of symptoms, we tend to focus on the neuropsychiatric symptoms as the symptoms of the disease instead of sort of taking into account that they may indicate underlying unmet physical and social needs, or that they may be related to symptoms from other comorbidities. So we know, what we do know is that some typical behavioral symptoms that we do see, depression, verbal abuse, wandering, agitation, and aggression may be all related, may be somewhat related to pain. And so there are increasing studies showing, but I don't think there will ever be one particular behavior that indicates pain. I think it's going to be more like there's a number of behaviors that can indicate pain. If we try and look and think about, well, how can we know whether people might have a good quality of life? This was sort of intuitive work that Kitwood did with years of working with people with dementia, and sort of came up with 12 indicators of relative well-being. So, and you know, we can talk about them a little bit. Basically, they break down into giving people a sense of personal worth, a sense of agency, and social confidence, so the ability to go out and be with other people, and a sense of hope. And so the ability to make some of your own decisions, to express emotions. So we often don't like to see a lot of emotions, but sometimes people get frustrating, and I always like to see it when staff can handle that and say, let me take a minute to come and talk to you and find out what's going on. Initiation of social contact. I have certainly seen that in the facility where the most unlikely people become friends. Being able to show warmth, social sensitivity, self-respect, acceptance of other dementia sufferers, humor, creativity and self-expression, pleasure, helpfulness, and relaxation. And these are things we can sometimes make out even in people where we cannot actually ask them how they are doing. So they can be very useful. So to finish, I thought we could have a bit of a discussion on what people feel needs to change in our society, and particularly in long-term care, to try and make change. I had hoped that I might have time to look at some of the long-term care standards that just came out today. I had a very brief look, and I must say it's hard to say. I mean, there's a lot of words, but I don't see any really practical stuff there, which I had hoped desperately to see. I don't know whether anybody else wants to make comments about what they feel needs to change in our society and long-term care, and what they'd like to see done differently, or if anybody even has any ideas of what they may be able to do with the constraints of their own facility to improve the quality of life for people with dementia.
Romayne, it's Trevor Jans. Can you hear me all right?
Yes, I can. Hi, Trevor.
Wonderful. Hi, Romayne. So one of the big things is the relationship with the personal caregiver. If you've got care staff who are kind and gentle and have a personal relationship with the resident, then their life is a whole bunch better than if you have a transient care worker who doesn't have a relationship with that resident, is in different parts of the building on different days, and builds no consistent relationship. So stability of the staffing such that the same caregivers are caring for the same residents as much as possible. And then permission and reward for the staff members to create that human relationship. I know you, I see you, I care about you. I've gotten to know the way you like your toast in the morning. I know when you like to sleep in until. I know what a good breakfast looks like for you. I know how to joke and tease and interact with you. And that human relationship between staff and residents, when it's going well, is a phenomenal contributor to their personhood and to their well-being. And in buildings where that doesn't exist, and staff are moved over and over again to different units and don't know the resident, and the resident is often very wary of care and very reluctant to be cared for by somebody who they don't know, often very personal care, the resistance to care is so much greater, and the lack of personhood and the demeaning behaviors where the caregiver will care for the resident without addressing them, without asking permission, without creating human relationship, without making that personal connection. There's a world of difference there.
Oh, I totally agree. And I guess what I'm thinking is, how do we mandate the facilities have to encourage and to pay their care aides enough to attract the people who are keen to do that kind of work? Because I think,
Yes.
that's part of the problem, isn't it? Is that they have a very difficult job, and
Yes.
a very labor intensive job for some people
Yes.
too. And I think You know, how can, I wonder if part of the suffering we've caused is by the view of this as being such an awful disease that nobody could possibly want to care for these people, which I know care aides who are worth their salt don't believe at all.
No, they're quite lovely. I want stable staffing in buildings where the staff are in a cottage and know the residents really well and are rewarded for and expected to create that personal relationship and to have that respectful communication style and ask permission and create relationship. There can be wonderful culture. And when you don't have that stable staffing and, oh, I'm new on this unit, and the caregiver and the resident don't know each other, there's just such a loss in that. So stable staffing is a piece, a culture that rewards the staff for having good, healthy relationships and gives them the freedom to time the meals and to time the personal care and to organize the life of the cottage such that breakfast can happen when the resident likes to have their breakfast. Breakfast can be flexible and might happen at 6:30 in the morning, or it might happen at 11:30 in the morning, and the nurses have the ability to time the medications and move with the resident schedule in that resident-centered way. That's a culture in a building that administrators can create or can crush depending on their policies.
Yes, absolutely. Now, do we have any care aides on who want to comment on what Trevor is saying and what I've been saying? You know, are we hitting the right tones in terms of encouraging stable staff, but encouraging people to do a very hard job and rewarding them properly? You know, and I certainly understand if you don't feel you can speak up, but I think that's something that really has to happen. I think someone's put something in chat, have they? Yeah, someone's saying here, I've also seen casual staff. Oh, this is actually, so there's been a few comments here. Better pay for nursing and care staff, the ability for them to take time off when they need instead of having to book 1 year in advance. Oh my God. I've also seen casual staff with these described skills. I think there should be more reward. The position should be more revered, absolutely. And I think when we don't revere the disease and we're frightened of it, that doesn't help. And then saying this is acutely worse. Personally, as many facilities in my area are so short-staffed that they now hire transient travel nurses. Oh dear. So these must be people who just come in. Oh my God. And they're not used to being working in long-term care. I think that's really difficult, isn't it? Because I'll never forget talking to some early days geriatric nurses, you know, or even nurse practitioners who'd say, how could they miss that person having a stroke, you know, that they sent in from long-term care? And I feel like saying, when everybody looks like they've had a stroke, it's damn difficult to tell. And when you've got, what, 30 some patients to look after, it's damn difficult. And, oh, here's someone saying, I'm a care aide in a gentle care ward. I agree with everything you're saying. Working with them at their level and on their time is the basics of what we can do. I guess the issue is getting paid properly, but also not saying, well, if we're going to pay you more, you're going to have to look after more patients. Because what you're saying is this takes time, and working on their time you know, may involve a lot of juggling and so on. So that's a very helpful message.
Dr. Gallagher, one of the other things too, when you're looking at health human resources is that ratio. And so we see ratios of one healthcare assistant to 8 or 12. And I know one of the new standards or goals that has come out in today's announcement was 4 hours of care per person. And so to me, if the sky's the limit, I would love to see a ratio for our care aides, healthcare assistants of one patient, one care aide to 2 I think there you would get fantastic
Oh,
care.
wow.
Yeah, wouldn't that
Yeah.
be wonderful?
That would be wonderful because I wondered about that 4.1 hours, whether that included, um, where sort of rehab assistance and all the other stuff, the sort of the fun stuff, not just the care stuff, got done.
I think you're right. It's including it all, but really, you see people sitting around, which means they're not engaged. And
Mhm.
that tells me we're understaffed. That's what that tells me. But, our ratios are what they are. And I don't have $1 zillion to fix that. However, if you don't dream and look outside the box, things don't change. And so I think that's important to really try and look on how can we do things differently so that we can have a better ratio and retain staff,
Yeah.
and it's hard on when people are casual or agency, doesn't matter who you are. If you're not there on a regular basis, it's difficult no matter what floor you're on. But it is in particular, again, who are we talking about? We're talking about the person, our clients who are, quite frankly, without them, we don't have a job. So we really have to go back to that and what's really important for them. And I think a massive restructure needs to happen to Health Human Resources. And I know I've been involved in many a discussion nationally and provincially on this topic. So I'll just get off my soapbox, but thank you for other comments that people have said.
Yeah, well, and thank you. That's great. So someone has said here in chat, I agree to support the health care aides in this education as well. Our long-term care program has received seed funding from Health Excellence Canada as part of the reimagining long-term care to help educate people on dementia care, more focused on how to reduce inappropriate use of antipsychotics and some of the behaviors. Part of the education will include You First Education Essential Conversations and orientation to health coaches. So there are positive things that are certainly happening. And I think what do we need to do about society? Because I guess would we have more volunteers if if people maybe had a different view and took the let's work with what's left versus the living dead sitting in those chairs? I wonder, what do people think? Oh, here's someone making a comment. I think since laundry and dietary has been added, this is diluting time spent. Oh, so some facilities have added laundry and dietary to the care aides job, I presume. Complex. Oh, yeah. Well, I think it's been awful, and I think I guess in the pandemic we really realized what an impact family coming in and family being able to feed and being able to help people. Yes, Carol is noting that families need to be included in the education aspect. I totally agree. Because I think families, they're trying to do their best, but sometimes people come in and say, I have the power of attorney, or I'm the healthcare decision maker, and I want to control how their care is done and things like this. And it's a real dance, isn't it, between family and staff. Now, have I missed anybody? So yeah, lower staff, better pay, casual.
Romayne, I hope I
Yes,
can jump in. My name's
please.
Ariel. I'm calling from Victoria.
Yeah.
I'd like to speak about it from the nurse's perspective, and I've got two thoughts on that. One is over the course of the pandemic, especially, but I've been in long-term care for about a decade. There's really been a push to have all the nurses on the medication carts. And I completely understand from a workload perspective that the more nurses on med carts, the lower the ratio of residents to nurse. So I completely understand it from that aspect. But the thing that I've seen go down with that change is that when something happens, like a palliative care patient is having a pain crisis, there's no longer a nurse who's able to give the time that's needed, which is time without a limit, to provide the care that you need a nurse to do. Not to say that there isn't a role for care aides, but when you're dealing with some of the complex medication things that come with that, I know when I got put on a med cart full time, that was really a challenge for me. And that's what made me feel like I was no longer doing a good job, was knowing, hey, I've got 24 other people I have medications to give before they fall asleep in the next hour. So that was really detrimental to me. And I've actually left long-term care, and that was the main reason. I now work in a cognitive clinic. So now I'm doing the pre stuff. But the other piece is I oriented so many nurses who were senior nurses, had lots of seniority, and they came into long-term care because they thought it was a cakewalk. They thought it was little old ladies sipping tea. And there's just such an incredible lack of respect for nurses and care aides and the specialized education that we have from working with these patients and their families. And I really think it would make a difference for it to be respected. It's not, I'm specialized as a geriatrics nurse. But if you look at job postings, they don't even ask for geriatric experience.
Oh my
And
goodness.
that's quite shocking to me, because it's a specialized area. No, it's not glamorous like the ER or ICU, but a good geriatrics nurse or a good geriatrics care aide, they're worth their weight in gold. And I want to say that to all of you on this call who are nurses and care aides. You guys rock.
Thank you, because I think that's so important. Because yes, I've run into people say, oh, long-term care. Well, when I went to do palliative care consults in long-term care, I found that some of the most complex patients were there with complex family dynamics, and they were usually, you know, the people who self-selected for long-term care were the people who wanted to keep having treatment and keep trying things. And my gosh, really, really challenging cases requiring hours of time, which nobody seemed to have. Now, Ariel, I appreciate your comment about the fact that if you're putting nurses on med carts, they're kind of focusing on tasks, instead of focusing on quality of life for people and what was happening in the moment. I know what Providence Health did was allow the care aides to give packets of pills, the regular pills. It still required a nurse to do the important things like PRNs and stuff like that. But so many challenges. Any further comments before we wrap things up?
I'm wondering if I could make a comment. I work in long-term care and have worked in long-term care for close to 16 years, starting out as a care aide or healthcare worker, and then becoming a floor nurse or an LPN. I really appreciate your comments about palliative care and pain. I think that is incredibly important to talk about, but I also feel that teamwork is incredibly important too. And when you're working with your care aides and your charge nurses and everybody works together, it makes light work for all. And I think it addresses all the needs, or a lot more of the needs of the people you're caring for, dementia patients and patients with complex care needs.
Oh, yes, absolutely. And I was always delighted when I could run across a care aide who said, or a nurse who said, yes, I know, Mrs. Lee. Yes, I know, Mr. Choi, right? Because then that made a huge difference, right? Than someone who said, oh, I don't know any, it's my first day here. That was always my dreaded comment was, it's my first day here, because then I thought, oh God, it's going to be tough because, you know, we rely on the observations, and people who can observe people's behavior are worth their weight in gold. They're very helpful.
Romayne, I've just got one more comment. It's Trevor again.
Yes.
Can I put in a plug for asking residents what their quality of life is like? And I've been surprised. You can ask somebody with even fairly significant dementia if you say, Bill, are you having any fun? And Bill will stop and he'll laugh at the question a little bit. And then he'll almost always give you an honest answer. And some will say, yeah. And you can prompt them. Is it the apple pie? Is it the music? Is it the, and they can say yes or no to other things. They can identify, yes, I'm still having fun. And some residents will laugh, a wry little laugh, and then they'll say, are you kidding? I haven't had any fun since my wife died, or since I had my stroke, or something else. And when we're getting ready for an advanced care planning conversation about whether we would want to go to the hospital, whether we would want to be resuscitated, whether we would want to have surgery if we had a hip fracture, whether we would ever want a feeding tube, that question about, are you having any fun, brings this to a really immediate level with the family members when they hear that dad's not having any fun. And if we did all these very heroic medical things to try and keep him alive for longer, when they've heard from the horse's mouth that dad's not enjoying this, and often he'll say, I just wish I was done. You know, I'm so done. When the end comes, I'll be glad to see it. They take people out behind they should just take me out behind the barn and shoot me.
Yeah,
And-
which is so sad, because I think we have to make sure that people aren't saying, well, okay, I will take you up beside the barn.
Right.
Right, because oftentimes it's the first segue into discussing, you know, their mood, their pain, their
Yes.
loneliness, their sadness.
Perfect. Wonderful.
Yeah.
Ask about all those things. That's wonderful.
Yeah.
Yeah. Pain, bowels, sleep, mood, quality of the food, quality of their interactions with staff. Yeah. All of those things. Is there anything meaningful that you do in a day? Is there anything that you look forward to?
Yes, because it's surprising what people look forward to. And I often remember my patient who said she would not commit suicide, not because of her son or her husband, but because of her cat. And, you know, people, that's where you need to learn about what keeps people going, and, you know, work on that.
Yes.
So, yeah.
Thank you very much for this talk, Romayne. It's been delightful.
Oh,
as
you're
always.
welcome. And it's been lovely hearing from people. And you know, I'm sorry we don't have a lot more time. I've got 8 more minutes, I think. If anybody else wants to make a comment, people have been saying in the chat here, funding and greater understanding of the importance of recreation programs and music therapy. Yes, absolutely. Music therapy is incredibly important, and I always remember there used to be a big lineup for the recreation time, so people could do you know, the bicycle or stretch their muscles and so on. So it's very important that we keep up those day-to-day things for everybody. So people are saying, is there a way to watch a repeat of this? And Jessica, maybe you could comment on that.
Hi there. Yes, I've just posted the link in the chat. So you can go through and have a look. That will be probably posted in the next few days, but all of our previous sessions are there as well.
Okay, and if people are interested, I will send Jessica a PDF of my presentation, but I think it's been the the comments and that has really made a great deal of difference. So I thank everybody very much for participating. Oh, this is interesting. Somebody's rec therapy ends at 4. Great. Thank you very much, everybody. And do you have anything to say at the end, Jessica?
No, just thanks again to you. Thank you so much for a
Oh,
wonderful
you're
talk.
welcome.
We appreciate you coming and speaking to us.
Okay, great. Thanks, everybody. Have a
Thank
good
you.
evening.
Thank you.
Right. Bye-bye.
Good evening.
Good night.
Bye. Good night.
Night, night.